Hello, this is Fred Goldstein coming to you live from the World Healthcare Congress, representing Health Innovation Media, and I'm joined by my bud,
Douglas Goldstein, eFuturist, Health Innovation Media. We're covering this conference with speakers, leaders, innovators, and people who actually get stuff done.
And ourselves. We're bringing you our thoughts, highlights, and unique concepts of what we really think is going on at this conference. And what do you see here, Doug?
I see deals being done.
Deals being done, but let's talk about some of the key stuff
But they
that came up yesterday.
start with relationships. Okay.
They do start with relationships. So yesterday we had some interesting presentations on by CC Connolly and her panel, and then we had the follow-on presentation talking about social determinants of health. The first one was on value-based care. Are we making progress? Did we hear progress yesterday?
There is progress, but the progress is enabled by technology, but the real progress is blocking and tackling. The social service agencies talking to the health systems and figuring out, or the provider groups figuring out how to coordinate to find those people who really have social needs and dynamics being driven by their environment that don't fit into the medical model.
So we heard a lot about that yesterday. It was interesting as they talk about we're going to take the 30% out now. They now recognize that 30% of this waste actually does exist in their system. But I wasn't sure when I heard it whether they were saying it was coming out of themselves or the others in the healthcare system to be applied to those social determinants issues. And it still is like, are the linkages created? Are they really going to get this done?
Well, they are being done on some level. I think whether they're going to be heavily funded is going to be challenging because everybody's living in their own silo of business models based on their grants or their government funding or however they're being sourced in the social service field and in the medical and health field.
Yeah, and I thought it was interesting yesterday on Twitter, somebody responded back to my comment about taking the 30% out and using it for healthcare. They said, yeah, they'll take it out and somebody else in healthcare will grab it and use it for something that's not needed. So it's hard to say where that's really going to go.
But I want to talk about shared savings, Fred, because it's interesting. In all this conversations around value and bundles of care, who does not participate?
Who?
We got the doctors, hospitals.
The
patient doesn't participate.
That's right.
What is that about? If we're trying to reduce chronic conditions and encourage people and support people in being healthier,
well, isn't that
none of those savings go back?
Isn't
really?
that why we're working on the community shared savings bill?
Well, that's right. We are working on a shared savings bill that's in Congress right now.
Yeah, we're hoping to get this thing dropped, and this bill would actually allow for Medicaid programs, the feds to publish the data out to the states. States would publish the top 20 issues or costly areas within the community in their Medicaid program. And if the community put in programs that generated savings, we're able to document those savings. Where does it come back to?
Comes back to the community.
That's right.
For economic development, health development, addressing food deserts, bank deserts, all kinds of
right. And believe it or not, who actually gets to determine how they spend the money?
The community.
There you go. We put the control in the hands of the local community to say, a local community board will be able to say, we want to use this, like Doug said, for either solving a food issue, a transportation issue, or some other social service need to continue to improve the health in communities. So we've been working on this with Ren Archer, the Chief of Staff to Congressman Fortenberry, and hopefully soon we'll have a bill drop that we can get some consideration through a committee in.
Well, and it's really important to recognize Ren because Ren is a physician. He's a former Commissioner of Health of Texas. He has seen the data at the state level, particularly in Texas, and he's seen the data and the experience across the country that communities that get along and have support are healthier.
Yeah, he also has a ton of knowledge about variations within communities themselves and how the social issues impact health. And so he's driving this thing as somebody actively involved in healthcare in a legislative role through Congressman Fortenberry, and obviously somebody who has deep knowledge to say, as a physician, here's some areas we need to focus on.
Well, and it's important to note that Ren comes from a long line of Americans that listen. He loves to talk about listening. His father ran Ways and Means for a long time.
That's right.
As a moderate, I guess what we would call, if we want to put labels on people, but we've got to stop doing that, a moderate Republican. But
Exactly.
We're all Americans first, and Ren is really a leader in this initiative around shared savings because of his view as a physician, as an American, as somebody who's trying to empower change, and his experience in Texas and other states.
Right, and if we're looking for behavior change, we've really got to come up with a way to help individuals themselves and communities recognize that they have an important role to play, and they're going to be rewarded for playing that important role versus just the potential incentives or rewards going to the providers in the healthcare system or the payers in the healthcare system.
So I think it's interesting. You recently have been in Mississippi, and you actually brought up this concept of shared savings in some conversations with state officials. And so can you explain a little bit about that?
Yes, I was in Mississippi doing a lecture on essentially diabetes, and talked about, obviously, Mississippi is the worst state in the nation for their diabetes issues. About 30%, they estimate 600 to 750,000 Mississippians are pre-diabetics. Most of them don't know it. 1 in 5 admissions in the state are due to diabetes. And the idea was, could you create an accountable health organization, a broad community as well as payer, healthcare provider organization, and then drop in a population health framework, capitate or value-based payment. The providers use the savings to fund the social services, and set a big goal. Not necessarily a moonshot. Some people don't like moonshots, but obviously you want to set a goal that people can grab onto, and then do the incremental steps, as Dr. Nick talks about, to get there. And the moonshot essentially is, could you eradicate lifestyle-based type 2 diabetes in the state of Mississippi, say in a decade or two? Obviously it's not going to happen tomorrow, but to make progress to that, and that's what we talked about. And they're actually launching a program in that state to start in a area around Jackson, Mississippi, and the contiguous counties.
So we're in the process of talking to states and also parts of counties and states that have rural populations that could really benefit from this, to build support in multiple jurisdictions for shared savings, and bringing that back so we can invest in social determinants of health or other things that are targeted relative to improving health status of individuals, families, and the population, the communities, towards what some people call blue zones or Wellvilles, or there's a community in Minnesota, New Ulm, that has made great strides through the Minneapolis Heart Institute Foundation in funding and reducing cardiovascular risk factors and diseases.
And it's nice to recognize that people are beginning to recognize, that the funds to solve those social determinant issues are locked up inside the healthcare system, and we've just got to come up with a way to release them by taking that unnecessary care out of the system. I will say that I met with the state director of health in Mississippi. She was very interested in this bill, as were others, and they're going to try to help us as well, and we're now lining up individuals to support us and organizations and talking to those groups. And on Sunday I was in a social determinants of health meeting for a short period of time and brought up the bill, and a number of those associations and not-for-profits in that specific session asked for more information, and I think we can get them on board to help us with this.
Yeah, so I think there's, with states like Virginia about to pass participation in the Medicaid coverage for individuals with a work requirement, then bring these savings back to support anything from training programs to vocational support, as people transition from previous era of industrial or information age jobs to really data industry jobs.
And obviously the whole issue of work requirements in Medicaid is a touchy subject. There's some concern that it's going to cause drops in Medicaid enrollment and things like that. And at the end of the day, I think, as was mentioned by a number of people, we need to get to a universal coverage situation, but at the same time we can't do that without some method of beginning to control these ever-escalating healthcare costs.
Well, and we know that that those costs are driven by waste, inefficiency, unnecessary tests. Some of that's defensive medicine, some of that is unnecessary intermediaries in the process. Some people point out PBMs. At the beginning and end of the day, I know we need care teams, health coaches, we need pharmaceutical agents in appropriate usage. We need someone to manage the efficiency of that, but we don't have to spend necessarily 30% of the premium dollar on those kinds of services.
Yeah, and just picture if we can go ahead and get Amazon, let's just give them as an example. Why can't they just drone those pharmaceuticals straight from the manufacturer to my front door? And if I happen to be one of the individuals who actually has the Amazon camera with Alexa, it'll open my door and the drone can drop it off, close it, lock the door, and leave, and I now have the meds at my home.
Well, and oftentimes we know these issues are just not logistical or technologically. We can do it technologically, but we have certain regulations guidelines, embedded interests that cause a problem with that.
Right. So perhaps somebody tries to hack the drone and have the drugs delivered to their house. So I guess we have to work through some of those issues.
I think there's more fundamental issues than that one related to unnecessary regulations or logistical challenges or, even states. If we looked at the whole telemedicine issue, right? I mean, a physician has to be boarded in the state to provide services.
Right.
That limits and raises costs for all the telehealth companies.
It does.
Raises major challenges. I mean, I was on a panel on Saturday with the CEO of Specialists on Call, and he was talking about how it took a year. He could reduce a cost for services in an area that needed hospitalists through virtual services. That they were spending $2.5 million a year. He could do it for $500,000, but there was a year plus delay between state licensure of the doctors, medical staff licensure for the particular facilities.
So
It's
clearly,
that process that raises a lot of costs.
and it clearly points to the need to make sure when we put in regulations or have these systems that we don't get these unintended consequences that just manage to increase costs continuously.
Absolutely.
Yeah. And so that'll have to do it today from World Healthcare Congress. I'm Fred Goldstein at FS Goldstein on Twitter.
And I'm Douglas Goldstein at eFuturist on Twitter and social.
And we are the brothers from another mother.